let's discuss about the anatomy of internal iliac artery. Now, this is one of the very important vessel that we as obstetricians should know, because this is the major vessel which supplies the pelvic viscera, pelvic walls, perineum, and also the gluteal region. Also, this is a very life-saving artery, because in case of hemorrhage, obstetric hemorrhage, we have to do the internal iliac artery ligation in case the uterine artery ligation doesn't suffice. So knowing its anatomy is of utmost importance. The source I have used is Steelens and Novak. So let's begin with the anatomy. First thing, very importantly, you should know that the internal iliac artery is also known as the hypogastric artery. Remember that the common iliac artery at the level of sacral promontory divides into right and left common iliac artery. Each common iliac artery at the level of the sacro-iliac joint, the lumbosacral joint, divides into external and internal iliac artery. The internal iliac artery is of course the medial bifurcation of the common iliac artery. 3 to 4 centimeter after its origin, the internal iliac artery gives an anterior division and a posterior division. Now this is of utmost importance, because when we are ligating the internal iliac artery, care should be taken so as to not include the posterior division. We are supposed to ligate only the anterior division. So understanding this part of the anatomy is important, that you have to leave 3 to 4 centimeter. The reason being that the posterior division supplies mainly the gluteus muscles. So in case you ligate the posterior division, the patient post-operatively will complain of the gluteal ischemia and pain in the buttock region, and it can lead to buttock claudication also. So after that, we should understand what are the branches of each division. So as I told, it gives rise to anterior division and posterior division. The anterior division first gives rise to the obturator artery. The obturator artery supplies mainly iliac fossa and the obturator internus muscle. Then comes your internal pudendal artery. Now this is the very important structure which is included in your pin structures which cross your ischial spine. So I'm sure you must be remembering from your anatomy days the structures which pass through behind the ischial spine, and the famous acronym is PIN. The I in that stands for the internal pudendal artery, which mainly supplies the perineum. It leaves the pelvis via the greater sciatic foramen and enters via the lesser sciatic foramen within the Alcock's canal. Next is the umbilical artery. Now this is the fetal remnant which becomes the median umbilical ligament. So this is important to remember. Medial umbilical ligament is nothing but the fetal umbilical artery remnant. Then comes your superior, middle, and your inferior vesical arteries, which of course supply the bladder, and also their branches supply the ureters. Next is the middle rectal, also known as the hemorrhoidal arteries, because these are involved in hemorrhoids. So these supply the rectum. Next is the very important artery which we have to know, is that it gives rise to the uterine artery. So it's the anterior division of the internal iliac artery which gives rise to the uterine artery. And as we all know, uterine artery supplies the body of the uterus and also the cervix, with branches to the upper vagina, fallopian tube, round ligament, and also supplies the ovary. Then comes your vaginal artery, which is again a branch of the anterior division of the internal iliac artery, and the inferior gluteal artery, which supplies the gluteus muscles of the posterior thigh. So remember, inferior gluteal artery is a branch of the anterior division of the internal iliac artery. Now coming to the posterior division. Posterior division mainly gives rise to three branches. So first is the iliolumbar artery, which supplies your lower abdominal wall, iliac fossa, and this is the one which anastomoses with your lumbar and deep circumflex iliac arteries. Next is your lateral sacral arteries, and third is your superior gluteal artery, which is very important, which is the major vessel which supplies the gluteus muscles. So that is why I told we are not supposed to ligate the posterior division during the internal iliac artery ligation. So this is very important to remember the branches, each branch and which part it supplies. Also remember that during PPH, the internal iliac artery ligation is a critical surgical intervention when there is intractable PPH. And how does it work? It basically reduces the pulse pressure in the distal branches, and thereby it controls bleeding while it preserves the uterine viability via collateral flow. So it's always a doubt in our minds that if we are tying a major vessel, then how come the blood supply will be there to the pelvis later? It is because there are a lot of collateral circulation and branches which are there, but the pulse pressure in the distal branches are greatly reduced when you do internal iliac artery ligation and that's precisely how it prevents PPH. Okay. Also, other applied aspects of this internal iliac is it is used. We should know this because the uterine artery, which is a branch of the anterior division, is important in uterine artery embolization, which is done, of course, with a team of the intervention radiologist, which is done in case of any tumor or fibroid where you want to manage it conservatively. So knowing its anatomy is of utmost importance. Even you should know that during many gynec-oncological surgeries where you have to do extensive pelvic pelvic procedures where you want to do lymphadenectomy or along with hysterectomy. So knowing the detailed anatomy is important, where you have to preserve the internal iliac artery and its branches. So now coming to the very important procedure where we are interested to know is the internal iliac artery ligation. Now this is the image from T-lens. So as you can see, this is the common iliac artery and vein. Okay. First thing I want to tell you is that in T-lens they have always mentioned internal iliac as hypogastric artery. Okay. So this other name of the artery you have to know. So this is common iliac artery and vein, and then they have told you this is the hypogastric artery. Okay. The anterior division of the internal iliac artery, also known as the hypogastric artery. Okay. So this is where this is the posterior division. Okay. So I'll just mark this is the hypogastric artery, which is nothing but the anterior division of your internal iliac artery. Time and again in T-lens they have mentioned as hypogastric artery, not writing it as anterior division. This is your common iliac artery and vein. This is your hypogastric vein, and this is your posterior division. Now let's see. So you can see ligation of the right hypogastric artery, where the clamp is passed from lateral to medial and the ligature is placed around the anterior division of the hypogastric artery, and the ureter is attached to the peritoneum, which is reflected medially. So we should know that the ureter is medial, okay, medial to your hypogastric artery, and you are pushing it away or reflecting it along with the peritoneum medially. Okay, so you are reflecting it medially, and this is the hypogastric artery, and you are passing the clamp. Okay, you're passing the clamp from lateral to medial. So from lateral to medial you are passing the clamp. Okay, and this is the ligature which you are going to, the assistant will make sure that this is a right angle clamp which you are going to place it almost 3 to 4 centimeter after its origin. Can you see, after the origin of the bifurcation, roughly 3 to 4 centimeter away, because we are not ligating the posterior division. After that, you're going to pass the right angle clamp below the hypogastric artery, and your assistant will give you the suture which you're going to hold, and then you're going to tie it. You're going to place one suture over here and one suture over here. Okay, so two places you're going to ligate and you're going to secure it. Remember, we do not divide the vessel, we are just ligating it on two places. Okay, so this is important. This is the steps which are given in the surgical control of pelvic hemorrhage. This is again from Thielens. So hypogastric artery ligation. Once the peritoneum over the external iliac artery from the round ligament to the infundibulopelvic ligament is opened. So you are opening the posterior peritoneum and you are going to reflect it. Remember, from where we are going, we are tracing it from the round ligament to the infundibulopelvic ligament. Identify the hypogastric artery at its origin from the common iliac artery or at the medial margin of the psoas muscle, and follow it up to the common iliac artery bifurcation. This is very important. You have to visualize the common iliac artery up to its bifurcation. Leave the ureter attached to the medial peritoneal reflection. So the ureter, we know, travels medially. Identify the hypogastric vein more laterally on the pelvic side wall. Okay, so the vein is more laterally placed. Identify the anterior and posterior divisions if possible. That's why they have written if possible. So in case you're not able to identify, it's always a wise decision to clamp it or to ligate it at least 3 to 4 centimeter away from the origin. Pass the clamp lateral to medial. This is the key step. From lateral to medial, you are going to introduce your right angle forceps, and 2 centimeter distal to the origin. Now here they have written 2 centimeter in Novak's and other surgical textbooks. They also mention 3 to 4 centimeter in anatomy textbooks. So you can remember 2 centimeter or 3 to 4 centimeter from the origin, and feed the non-absorbable suture into the tips of your right angle. Place a second free tie, as I told, distal to the initial ligature to avoid recanalization, and tie down the suture. Do not divide the vessel. This is important to remember. Okay. Now this is a nutshell about the internal iliac artery and its applied aspects. I hope you found it useful. If any doubt, feel free to write in the comment section, and if any other topic you want me to discuss, I'll be glad to do. This is very important topic for all the residents, and as surgeons we have to know. That's it for now. Bye bye.